to SCNM's webinar. Thanks so much for joining us this afternoon. To those of you that will be starting at SCNM in the fall, congratulations. We're excited to have you on campus in just a very short 5 weeks. And to those of you who are on the call who are learning more about naturopathic medicine and SCNM, welcome. We're glad to have you on the call this afternoon. My name is Eve Velotis, and I will be your host for today's webinar. As you've gathered from the webinar description and the letter that accompanied your book, each year we give incoming SCNM students a book prior to coming into the program. Past books have been written by NDs about various conditions, but this year we decided to shake things up a bit by giving you a popular bestseller that hopefully has started to get you thinking differently about medicine and medical diagnosis. But before we dive into the presentation, I want to take a couple minutes to familiarize you with the technology that we'll use for today's webinar. For those of you that have been on our webinars before, you'll be familiar with this. Hopefully you can see the control panel on your screen, like the one shown in the box here. If you don't see the box, look for the double arrows and click on that. Make sure that you can see, this is how you'll ask questions in today's webinar. So hopefully you can see that question box, and we'll have you type your questions about the content into that box, and we'll address your questions verbally at the end of the presentation. We anticipate today's webinar to run approximately 60 minutes, 40 minutes of presentation, followed by about 20 minutes of question and answer about today's content. Now, for those of you that are starting the program in the fall, I know you're very familiar with this slide and what naturopathic doctors do and how they do it. But for those of you that are newer to the medicine and still learning, NDs concentrate on whole patient wellness, attempting to find the underlying cause of the patient's condition rather than focusing on symptomatic treatment. And NDs use the 6 principles that you see on your screen to treat patients. So one of the things that, of course, is so important to naturopathic doctors and all doctors is being able to figure out medical diagnoses. And that's what Dr. Howell will address today in her remarks about Nate Silver's book. So today you will be hearing from Dr. Howell. Dr. Pamela Howell teaches general medicine classes that you'll have in the 2nd year of the program. She is the chair of clinical diagnostics here at SCNM and has been with the college since 2002. She's the course coordinator for the General Medical Diagnoses course series and is also faculty member for the clinical practice course that you'll have in your 1st year. In her time at SCNM, she has also taught medical ethics, dermatology, pulmonology, and emergency medicine. She received her MD degree from Texas Tech University Medical School and completed a pediatric residency in the years following. Dr. Howell was a pediatrician in private practice for 12 years before she moved to Phoenix with her fiance when he started school at SCNM. So please join me in welcoming Dr. Howell, and please give us just a second as we transition slides. Take it away, Dr. Howell.
Good afternoon and welcome. I'm glad that you could be here today. I'm very passionate about teaching and about medicine, and so I'm glad that you can be here, and I hope that we can have a meaningful conversation this afternoon. I want to start by telling you that when I was asked to do this by Dr. Mittman, president of our college, I was kind of curious as to why I would be asked to talk about a book that I initially thought had to do with politics, the economy, baseball prediction, and meteorology, because I'm not an expert in any of those fields. However, after I started to read the book, it became very obvious that there are a lot of parallels to medical diagnosis that can be drawn from this book. And I have to tell you that I was very excited to be asked to do this project because it turned out to be one of the most fun ones I've been asked to do since my time here. I thoroughly enjoyed the book, and I hope that you did as well. And I just want to get started by introducing the author. He's many things that I am not. He's a statistician, a mathematician. He's a blogger for the New York Times. He blogs for ESPN. which I feel I could almost do because my husband watches ESPN practically 24/7. I know a lot about sports, but not nearly as much as Nate Silver. He developed a system for baseball forecasting called PECOTA, and basically this is a system for Major League Baseball to decide who the players are that they want to spend millions of dollars on. Now, in medicine, as primary care physicians, we're not concerned with millions of dollars, but we're concerned with something that's even more important than that. In medicine, we're concerned with people's lives, and that is far more precious than money. So what I'm going to do as we go through this discussion of this book and the presentation is to tell you how it relates to medical diagnosis. First off, we have some definitions to talk about. And in his book, the main thrust of the book is he thinks we need to have an attitudinal change overall in how we make our predictions. And in medicine, this would be how we make our diagnoses. There's a difference between information and knowledge. Sometimes we think that we want more information, but actually what we need and what we're trying to get at is more knowledge, which brings us to the signal versus the noise. The signal is the truth. The noise is what distracts us from the truth. And then there's a difference between accuracy and precision. So precision is hitting the same, quote, target every time in the same place. But that is different than accuracy. Accuracy is actually getting to the truth. So if you're precise, you may be getting to the wrong diagnosis every time, and as a physician, that is not the ideal. So let's talk, in the book he talks about the first 3 chapters are concerned with failures of prediction, and some of these failures are more epic failures than others. One of them was the economic failure during the late 2000s, and he talks about the bursting of the housing bubble and how that could have been predicted but was not predicted. Political predictions. So when you watch television, especially during election seasons and there are political pundits on TV, they make their predictions. And they are very certain about their predictions for the most part. But when Nate Silver did a study of how accurate these predictions were overall, he came up with an accuracy rate of only 50% from all of the political experts. And he says that part of this is due to the personality of people that are in the media. And he says that they are more like hedgehogs. So I wanted to kind of talk about that a little bit. Hedgehogs, he says, are people that tend to be very ideological, stubborn, and rarely change their predictions, even in the face of evidence to the contrary. Foxes, on the other hand, tend to be more adaptable, self-critical, and multidisciplinary. And so in the media, people tend to be more hedgehogs because they're more interesting to listen to, they spark more controversy, and the foxes are usually behind the scenes. We need to express and quantify uncertainty. When we make a prediction or when physicians have a diagnosis, they need to quantify and express how uncertain they are about that prediction. And we're going to talk about that in more examples as we go along. It is important as physicians to realize what biases we may have. It's impossible to completely eliminate all biases that we may have, but when we are seeing patients, we need to try to be as objective as possible and realize what our biases are up front and to try to put them to the side when we're seeing patients. Another thing that we need to do is update our diagnosis or our ideas as we go along and new information comes in or circumstances change. And so I want to relate this to a doctor's office visit, an initial visit in a doctor's office. A patient will come in with a complaint, and as soon as you begin talking with the patient, you should think on a very big scale, a very general scale, about what these symptoms could be related to. And then as you take the history from the patient and you talk with the patient, you start to refine that list of possibilities. After that, you do a physical exam. at which time you get more information, more facts come in, and then you can refine your ideas even further. But you're not done there. After that, you may need to order lab work, x-rays, other imaging studies to further try to define the diagnosis. And even after that, once you treat the patient, you need to follow up with that patient and see how they responded to that treatment. So through all of those steps, you need to have an open mind and be able to revise your initial ideas as new information comes in. You also need to be able to decide what part of that new information is signal and what part of it may be noise. So in the book, he talks extensively about baseball prediction, and I suspect part of that is he developed PCOTA for the Baseball Prospectus book, and he's very involved in ESPN and predictions. And I don't know how many of you saw the movie Moneyball, which starred Brad Pitt as Billy Bean, and I believe Jonah Hill was the statistician. And basically the movie is about the change in baseball predictions and hiring to involve more statistical methods. And in the book they talk about scouts versus stat heads. And so basically, years ago in baseball, typically what they would do is send out scouts who knew baseball, and they would get to know the baseball players, and this was quite helpful to decide who was going to be hired by the different teams. And then a change occurred when statisticians came in, and the slant was more towards statistics. Well, as in most things, when you have two very different methods, the truth lies somewhere in between. There are biases in both approaches. For example, some things are very hard to quantify and to look at in statistics. And so if we're talking about baseball, defense is very hard to quantify. You know, runs batted in, that is much easier to quantify. And so other things that are difficult to quantify is not patients, but baseball players' responses to things like a slump or to bad press. So if you have a baseball player that has wonderful statistics, but when they have a slump or they have negative media reporting, they fall to pieces, then that is a huge risk factor in hiring that baseball player. And so when we talk about people that are able to make good predictions, we understand that these people need to think both very big and very small. And what that means, and we'll talk about this in class, is that you have to be able to see the big picture, but you can't forget the details. And so as you go through school, I'm going to talk about that in the medical diagnosis classes over and over, seeing the big picture and yet paying attention to the details. The key is to look for your information in the right places and then to interpret those details with as little bias as possible. In the book, Nate Silver then starts to talk about weather forecasting, and especially about the failures of prediction with the Hurricane Katrina. Now, one of the theories he talks about in the book is chaos theory in different systems. Now, chaos theory does not mean that events are completely random, that there's no natural laws. It just means that in a system that is operating under chaos theory, it's very hard to predict what's going to occur. And so chaos theory applies to systems that are both dynamic and nonlinear. And I would argue that the spread, for example, of infectious disease approaches chaos theory. It's very hard to predict what is going to happen. Systems that are dynamic, what that means is that when one event occurs in time, it affects behavior at another point in time. And that happens if you just think about the human body. When one system fails, another system may fail. And so that's why human beings are in a dynamic system. Also, nonlinear means that changes occur exponentially rather than in an additive fashion. And so this applies to medicine because when we talk about things like disease prediction or susceptibility to illness, that is a dynamic system that is occurring. Now, weather forecasts are very vulnerable to inaccuracies in data. And as soon as you get about a week out, it's very difficult to predict the weather because chaos theory is introduced at that point in time. Now, Katrina taught us a lot of things about prediction. And probably the main lesson, according to Nate Silver, is that accuracy is the best policy. And what that means is lives could have been saved if there was more transparency, more accuracy in the forecast, and if the officials involved put aside politics, personal glory, and also economic concerns, because there were a lot of problems initially with Katrina because there was a fear of panic and also a fear of lost revenue in the city because it's a tourist city, so a tourist destination. So there was a lot of problems with accuracy and transparency of reporting because of that. Next, Nate Silver talks about the problem of overfitting. And basically what that means is mistaking noise or information points for signal when all they are is noise. So if you look at these three diagrams, you can see that these orange dots represent data points. And so if we underfit this, what we're looking for is an underlying pattern, which in this case is the truth. So in statistics, we call it a pattern. If we're talking about medicine, we call it the truth. So we're trying to figure out what all this information means. And if we just draw a line such as this through it, we're not connecting enough of the dots. So that's called underfitting. Overfitting means that we try to connect every single data point. Well, that takes us away from the pattern as well. Because if we look, this is sort of like the three bears. Just right is in the middle. And that basically means that we try to realize that there are outlying data points, but there's really an underlying pattern. And so that's the diagnosis that we make, is the truth or the pattern. And when we try to connect everything that we get back, so the more lab tests you order, you get more information. But does that really mean you necessarily get more knowledge? And the truth is you do not if you try to connect every single bit of that information. So I have an example of someone on television, a medical TV show, who did this. And I know there's people out there that have seen the show House. And one of House's standard lines was that there are no coincidences, that everything that you found out about a patient was connected. Nothing was a coincidence. Nothing was an outlying or confounding factor, and that everything had to fit into one diagnosis. Well, that's not really true. That's not how it works in medicine. So a lot of times you will get a lot, even conflicting information when you order your labs. And that's because people don't read the medical books for one thing, but also because someone can have two conditions at the same time. One condition can affect another condition. So labs can seem to be contrary, but if you understand the medicine and you keep an open mind and you continue to search for the truth, you can get to the pattern, the signal, and the truth eventually. So we really have to be careful in medicine that we convey to our patients our level of uncertainty when we talk with them. A good example of this is, let's say we have an individual who can't swim, and they're talking to a local in the area, and the local tells them, oh, that river right there, that's 3 feet deep. You can get across that just fine on foot. You can get across there. And he doesn't tell the individual that it's 3 feet deep on average, which means that there's a probability or an uncertainty that it may be deeper than that or more shallow than that. So in other words, if you don't convey that it's 3 feet only on average, that person could drown crossing that river. And so what that is concerning is somebody that is overstating the reliability of their predictions. So in medicine, we try to stay away from that. We should never tell a patient, well, I'm 100% sure that I can cure you, or I'm 100% sure that this is what's going to occur if this happens. We as physicians have to be very conscious of what are the probabilities and what our uncertainties are. And we have to be very honest with ourselves about our abilities. Okay? So we don't overstate our predictions. And I know that you've seen this in the media with politics, with the economy. A lot of those hedgehogs tend to overstate the reliability of their predictions, and as we've seen, they can be wrong half of the time. One of the things that's important is that correlations are not the same as causation. So I'll give you an example from the book. Two things that occur in the summertime are that there's an increase in forest fires and there's an increase in ice cream sales. Well, they're correlated because it's the summertime, but one does not cause the other. And that's eminently obvious. And so that's a good example. In medicine, for example, as a pediatrician, in private practice, I've seen a lot of infants and infants with ear infections and teething. And it just so happens that teething occurs in the infancy period, and so do ear infections, more commonly than later in life. So they both occur at the same time. But many parents assume that teething causes ear infections. Now, physiologically, that does not happen. They just tend to happen at the same time. So in medicine, we really have to be careful, whether we're looking at research or treating patients, to try to determine whether things imply causation or whether it's simply causation. Another mistake that we human beings tend to make is that we tend to see data the way we want to see it. So I can guarantee you that two people can look at some bit of information the same way, and depending on their viewpoint, can have completely opposite predictions. A perfect example would be if you talk to a conservative political pundit and a Democratic political pundit. So if you put those two together and gave them the same bits of information, I guarantee you that you would get two opposite viewpoints. So we need, as physicians, not to be that way. We need to be as open-minded as possible. We need to search for truth and be willing to see opposite viewpoints and actually seek out opposite viewpoints sometimes to help us. So the one chapter in the book that's devoted to medicine and disease prediction has to do initially with the Fort Dix Flu Fiasco, as I like to call it. This happened in 1976, and there was a soldier who had flu symptoms, and he decided to go on a training exercise that was very rigorous and physically demanding, and he collapsed and died. Well, because a young, healthy soldier died on base, and on base there's very close quarters and disease can spread quickly, a blood test was sent to the CDC, and it was determined that this soldier had died from the H1N1 virus, or the swine flu virus. So this raised a lot of fear and a lot of concern because the swine flu virus, the H1N1 virus, killed 50 million people between 1918 and 1920. It was a horrendous flu pandemic, and as you can see, it killed very many people. So that's pretty frightening if the same virus has now been found at Fort Dix. Also, and coincidentally, that flu pandemic that killed all those people started at another Army base in the United States. So there was a correlation there that further made people very nervous in the public health sector. It started at an Army base, so it was concluded that on top of some very flimsy evidence that we tend to every 10 years have a major flu epidemic, and that we were, quote, due for another one because the one previous to that happened in the late 1960s, that, oh my goodness, it's starting at an Army base, it's the same virus, and we're due for a big flu. Because of that, there were a lot of dire predictions, and the president at the time was President Ford. And President Ford, anybody that watched Saturday Night Live in those days, was very definitely made fun of as being a very ineffective, indecisive president. And so to try to change his image, he decided that he was going to do something about this situation and make a decisive move. So he ordered a vaccination program, which included television ads. And these ads would just terrify people For example, there would be a picture of a person gardening, and then in the next frame, the person is in their coffin. And the message was, if you don't get your flu vaccine, this is what could happen to you. So people were getting very scared. The president ordered vaccine to be produced very hastily to the tune of $180 million, and people were encouraged to get the vaccine. Unfortunately, as the vaccine was being given, people started to come down with a neurologic illness which caused problems with weakness that started at the feet and moved up the body, called Guillain-Barré. Now, Guillain-Barré can be fatal. It isn't necessarily fatal, but it does cause weakness and paralysis. And 500 people were found to have developed this immediately after getting the vaccine. So eventually, the vaccination program was thankfully discontinued. And after all was said and done, only one person died from the swine flu, and that was the first soldier at Fort Dix. So that was an example of a prediction that was made based on flimsy evidence, emotion, a quest for personal glory, appearances, and it actually harmed people and basically did not help anyone. Now, that being said, there are a lot of difficulties with disease prediction. One of those is to know how to predict how something is going to act and spread through a community. It has to spread through the community before we can tell. Some of the things that we use to try to make predictions are things called reproduction number and fatality rates. Well, fatality rates, that's easy to understand, how many people will die if they get this infection. Reproduction number refers to how many people can one person infect. So a reproduction number of 3 means that one infected person will infect 3 more. That's pretty hard to predict at the outset of an illness. And so we have to try to make an educated guess. And in class, we're going to talk about educated guesses all the time. You have to have some base from which to decide what you think it could be. Now, there are self-fulfilling predictions. So when there is media coverage of a condition, it's no surprise that there's increased reporting of that condition. For example, with the H1N1 virus, if the media tells people that the symptoms are fever, sore throat, and a cough, people are going to go see their physician that would not normally go see their physician for a fever, a sore throat, and a cough. And so there's going to be an increase in reporting by physicians. Some will be misdiagnosed and reported as a case. And that's just no surprise. The more coverage there is of something, the more reporting there is going on. There's also self-canceling predictions. And in the book, he talks about the use of GPS for traffic navigation. And he says that, your GPS tells you to take an alternative route because there's less traffic. And then it also tells everyone else on the road to take that route. So pretty soon, the route that was less congested now becomes just as congested. So epidemiologists are people who study communities and disease among populations of people. And when we compare epidemiologists, people in public health sector, or physicians, they tend to be, as a group, more aware of their limitations in prediction than political pundits, economists, people in the media. And that's because there's more at stake. If a physician, a public health official, bases predictions on, quote, a stupid model, according to Nate Silver, people could die from that. And so when you're seeing a patient, if you're making a diagnosis based on lack of information or something that is incorrect, or your emotion or your quest for personal glory, you could actually harm a patient. And all physicians, naturopaths, allopaths, operate under the notion of primum non nocere, which means first do no harm. That is a physician's call. We must not hurt people. And so, excuse me, we tend to be more concerned with uncertainty and conveying that to our patients rather than making these predictions that we say that we're very reliable to make. Now, at a couple of major schools, University of Pittsburgh and University of Chicago, there excuse me, are multidisciplinary panels that have started to create what are called sim cities. So I don't know if you've ever played the video game, The Sims, but basically what they're doing is they are setting up things called agent-based models, or models of communities or counties or towns, where they try to take into fact that there are different socioeconomic statuses in that community, different cultures, and what they try to do is assess susceptibility to disease and spread of disease within communities. And so on their staff, they have cognitive psychologists, behavioral economists, physicians, so that they can start to study these things and get insight from these models so that maybe someday we will get better at predictions of things like disease through communities. Getting to the heart of the book, and one of the theorems that Nate Silver believes in is Bayes' theorem. Now, Thomas Bayes was born in the early 1700s. So this is not a new theorem at all. It's basically controversial. There's Fisherian methods, and we're not going to go into statistics, but this has been around for a long time. And basically, it's attempting to connect probability, prediction, and scientific progress. And Bayes' theorem centers around the probability that a theory or a hypothesis is true if some event has occurred. And in this theorem, the mathematical equation, there are 3 known variables, and for the sake of discussion, we'll call those X, Y, and Z. And then the unknown is that it's called the posterior probability, or the probability that your theory is correct after an event has occurred. And so the best way to talk about this is to kind of give some examples. One thing I want to talk about is prior, or prior probability. The prior probability, we're going to assign X. And the prior is something that you need to know or at least have some idea of. Y is the probability after the event has occurred that the event has occurred based on why you think it occurred. Z is the probability that the event that happened doesn't have anything to do with your theory. And then the posterior probability is that unknown that we're looking for. So this is your revised probability after an event has concerned. Or we could say your revised diagnosis after evidence has come in, which you hopefully are continually revising. So let's give an example. This is in the book, and they're talking about the probability of a terror attack on the World Trade Center. So that's your prior, okay, that's X. So prior to anything happening, okay, the probability of a terror attack occurring on the World Trade Center, we could say was 0.005%. It had never happened before. So if you assign that probability, you're saying, because I know history, that's what I think. Okay, so the whole equation depends on having a good prior probability, and we'll get to that. So Y is the event, the first event, when the first plane hit the World Trade Center. Okay, we said that Y, going back a slide, is the probability of the event based on the theory, in this case, that there's an attack on the World Trade Center. Okay, so after the first commercial airliner hits the World Trade Center, we're going to say the probability that it's due to a terror attack is about 99%, because there's never been an accident where a plane flew into the World Trade Center, a commercial airliner. Z is the probability that this event, the first plane hitting, was an accident. That's about 0.008%. And so if you do the math, and we're not going to do the math here, but he does it in the book, when you plug in the numbers, the posterior probability, which is the probability after that first plane hit that this was a terror attack, is 38%. So you see here you said, well, 99%, but in actuality, it's 38% when you do the math with Bayes' theorem. Now, to go a step further, that wasn't the only event event that occurred. So more information came in. Unfortunately, a second commercial airliner hit the World Trade Center. So, like I said, as new information comes in, and according to Bayes' theorem, we have to redo the math. So now X is now the probability of a terror attack on the World Trade Center after one plane has hit. It's 38%. So now this number becomes 38%. Okay? That means that when we plug those numbers in, the posterior probability of X after 2 planes hit the World Trade Center, when you do the math, it goes up to 99.9% that this is a terror attack. And so I'm not focusing on the math in this. I'm just showing you how when you get new information, you have to redo the theorem, and you have to apply that, and it changes those values. Another example given in the book, when we talk about false positives. In medicine, when we get lab tests, we do studies, it's never perfect, which means that we can have a person have a lab test done, let's say for strep throat, and it comes back positive. Well, a test is only as good as how specific and sensitive it is. And so ideally, if someone has a positive test for strep throat, we hope they really have strep throat and that it's not a false positive. Likewise, if we do a test and there's a lot of false negatives, we won't catch people that actually have the disorder. So we're going to talk about mammograms, and specifically about mammograms done on women in their 40s. We know the prior probability because we know the incidence of cancer, breast cancer, in women in their 40s, and it's 1.4%. That means that our prior probability, or X, is 1.4%. The probability that a positive mammogram is really due to breast cancer is 75%. The probability that a positive mammogram is not due to cancer but is a false positive is 10%. And so when you plug the numbers in, the posterior probability for the chance that a woman in her 40s who has a positive mammogram actually has breast cancer is only 10%, which leads us to believe that doing mammograms on otherwise healthy women with no history of breast cancer in the family, there's only a 10% chance that if she gets a positive mammogram, it's really breast cancer, which means that there's a high probability that it's a false positive. So now we get down to information versus knowledge. And we know that in our society there's been an exponential increase in information availability just in the last 20 years. However, the meaningful relationships between the data points is much smaller than the amount of information that we have. In medicine, there is so much information available to us. And the trick is to decide what's the signal, what's the noise, and to determine between causality and correlation. There are a lot of research studies out there that tend to make data fit their theory, rather than completely in an unbiased fashion testing the data and testing the hypothesis. In other words, there's a lot of overfitting that's being done and underfitting. Now, we know perfection is completely impossible, but what we want to strive is to be less subjective, less irrational, emotional, and less wrong. So we can't be perfect, but we should try to be concerning ourselves with a greater truth beyond our personal circumstances. A lot of times these are based on psychological biases or misaligned incentives, etc. But the scientific community must converge toward the truth. Incorrect beliefs or wrong prior probabilities have to be revised and revisited as new events and evidence occurs. And we see this in medicine. A lot of times we have done things, and I can speak to allopathic medicine and the treatment of newborns that have jaundice. So jaundice in newborns is a physiologic condition, meaning that it's very common to see and doesn't necessarily mean that there's a problem in the infant. it was just decided upon that a certain level of bilirubin in the blood, which is what makes you jaundiced, might get into the brain. So we randomly said, well, at this level, they all need to be put under a bilirubin light to break down the bilirubin. It took 30 years for the medical profession to say, you know what, there's a lot of evidence that says that never happens. The bilirubin does not get into the brain and cause a condition called kernicterus at those low levels. So we don't really need to be that concerned with using a bilirubin light at those low levels of bilirubin. And thankfully, it only took 20 years, the evidence caused us to revise the priors and the prior probabilities, which then impacted the treatment of newborns with jaundice. Part of the reason is, well, we've always done it that way. But another problem is that we have to be honest with ourselves and skeptical about our abilities and listen to others, which is sometimes a very difficult thing to do. It would seem on the surface that there are not a lot of egos in medicine, but let me tell you, whether it's naturopathic, allopathic, there are a lot of egos involved in medicine. And so as an individual, treating an individual patient, we need to be very realistic about our abilities. No theory is perfect, and we must continually refine and test hypotheses in medical research. Now, a little bit about the art and practice of medicine, and so this would be concerning ourselves as individual physicians, is that we don't want to overfit noise. We don't want to concern ourselves with the noise, or at least we need to be able to recognize the noise so that we don't confuse correlation with causality. One of the reasons that you start medical school and you start to learn the basic sciences is that you have to have an adequate knowledge base. And if we want to relate this to the signal and noise in Bayes' theorem, an adequate knowledge base improves our prior probabilities. If we don't have an adequate knowledge base, it's very difficult to determine what someone's diagnosis might be, and we tend to be very much more biased unless we have that adequate knowledge base so that we can develop adequate priors. Another thing that we need to understand is that it's very important for our patients to know what we don't know so that we cannot do them any harm. This is the basis of being safe when you're in medical practice and not causing patients harm. I always say it's important to know what you know, but it's even more important to know your limitations and know what you don't know. So an example of this would be when I was a medical student and a resident, we were taught how to suture, and we were perfectly legally capable of suturing a 6-year-old's face. But if you don't do that all the time, you're not the best one to do the job. So yes, legally you can do it. Yes, your board might say that you're capable of doing it, but if you know you're not the best person for the job, and this could leave a scar on a 6-year-old's face, why would you do that? And so you have to put your ego aside and say, you know what, I'm not the best person for this job. Let me refer you to someone else. And as a physician, you need to do that on a regular basis. You have to check yourself before you wreck yourself, and that's a really important thing to do. And without an adequate knowledge base and without a humble spirit and an ability to really know what you know and what you don't know, you could hurt someone. You have to recognize your biases and keep an open mind. And one of the problems is you think a patient has a certain condition, and you get evidence in to support that, but then you get some evidence that does not support your diagnosis. What do? Do you ignore the evidence that doesn't support what you think it is? I hope not. I would think that with new evidence coming in, that's the time to reevaluate what you were thinking in the first place. And that is how you become a good physician rather than a dangerous physician. And of course, continually revising your prediction or diagnosis based on new information that might come in, basically paying attention to the signal. And that concludes the presentation portion. If you have any questions, please type them in.
Great. Thanks so much, Dr. Howell. That was very interesting and very informative, a great breakdown of the book. As Dr. Howell mentioned, now we want to answer your questions about the presentation or any concepts that you read in the book that you have questions about. So type those into the question box that is in your control panel. So Dr. Howell, can you talk a little bit about how the curriculum at SCNM will prepare us, the questions from the student, to help with the process of distinguishing the signal from the noise?
Okay, so basically when you come into school, the first year you're going to be learning anatomy and physiology, among other things, and this is really important. And then you will also start to learn lab diagnosis and things like that. So what we're going to do is, first we're going to present normal physiologic functions, normal anatomy, and then in the second year we move to pathology, which is the study of disease and how normal changes with different conditions. At the same time, we incorporate lab diagnosis, physical exam, symptoms, the history part of what the patient tells you, and we'll help walk you through the differences and similarities between conditions so that you can start to see what might be signal and what might be noise.
Great, thank you. Early in the presentation, you mentioned the importance of looking at the big picture, but also paying attention to the small details. Can you give a real-life example of that, what that might look like?
Yes. For example, someone comes in to see you, and this is an example from my own experience. A person comes in to see me, and it was a patient that I've been seeing for a long time, had swollen glands, had a sore throat, had a high fever, saw the patient, did a rapid strep test. It was positive, which is what I would have assumed it might be. I treated the patient with antibiotics for strep pharyngitis, and 2 days later, the mother called me and said, now she cannot swallow water, she's getting very dehydrated, and she's getting worse. So at that point in time, I had seen the big picture, I thought I had looked at all the details, and I realized that I had to revise my diagnosis, that I had to think outside of the box, and I had to see the patient again. And what I did was I admitted the patient to the hospital for hydration, and as I was thinking, I had to step back and look at the big picture again. And I thought, what else causes swollen glands? What else causes a fever? She's a teenager, and it hit me, infectious mononucleosis. And so after I had admitted her, I did a test for the Epstein-Barr virus, which causes mono, and it was positive. So this is a case of someone having two conditions at the same time. Had I stuck with my original diagnosis and been stubborn and patted myself on the back, I would never have diagnosed her with the infectious mononucleosis.
Great example. And I think that ties into the next question, which is just this whole concept of mistakes happening in the medical profession. How, not to generalize, but how often does that happen? And again, what can ND students do to not get themselves in traps of making mistakes?
Well, first of all, mistakes are inevitable, and we all need to realize that we're human. The worst thing you can do if you make a mistake is to try to cover it up or hide the fact. That could cause even more damage. So if a mistake is made, it kind of depends on what that mistake is, but you need to own it and call it out as soon as you find out that you made a mistake. A good thing, and I spoke to this a little bit already, but knowing what you don't know is really important. And so a mistake sometimes that physicians make is that they pat themselves on the back, I made a difficult diagnosis, and they think that the responsibility ends there. And they don't want to refer to or ask anyone else for help because that is somehow going to affect their ego. And you need to understand that when you are talking about your relationship with your patient, your ego takes a back seat. And it has to do that. And so, like I said before, if you know you're not the best person for the job or if it's beyond your capabilities, you need to know when to refer and how to refer correctly.
Great, thank you. Any other questions? If you have those, make sure to type them into the question box. And also just a reaction, did you enjoy reading the book and kind of seeing how Nate Silver applies concepts to medicine? You can type your responses into the question box as well. Again, on this slide here, Dr. Howell, you talk about correlation versus causality and not overfitting the noise. I imagine that that's really easy to do.
Very easy.
How do students not get in the rut of doing that?
Well, part of that is just part of the learning process. Students initially will do that, and it's sort of like when you're in a classroom and we're talking about a specific condition, you tend to get that condition as a medical student. For example, when we as medical students were being lectured to in our psychiatry rotation and we had a psychiatrist talking to us, we didn't imagine that we had the conditions, but we pointed fingers at everybody else in our class. So when there were personality disorder questions, I thought about other people in the class. But it does tend to be a problem that students will pick up on symptoms, and you know, when you first start in medical school, you know enough to rule things in, but you don't know enough to rule things out.
That makes sense. That's great feedback. Thank you. All right. Well, last call for any additional questions.
I just wanted to respond to a comment because I kind of thought this too, to some degree. Somebody says that they thought the book was too much noise and not enough signal, and I tend to agree with that on some things, and that's just simply because I'm not a politician, I'm not involved in politics, and so there were a lot of specifics about things that I didn't know much about, nor did I care to know about. However, I was able to connect a lot of those things to medicine, so that I thought it was a pretty good book.
Awesome, thank you. And there is a question from somebody who did not get the book in advance, a student who's not coming into was not accepted into the program yet. So the book is available on Amazon or bookstore. It's a New York Times bestseller, so you should have no trouble finding it. So great question. Does understanding your limitations come with time, and how does somebody sort of develop that skill?
First of all, yes, understanding your limitations does come with time, because as you go through the program, you learn what your personal limitations are, and also what the limitations of medicine in general are. And the most important thing is to realize that nothing is perfect, and neither are you. There's no lab test that is perfect or treatment that is perfect, and so you will learn that with time.
So another question that says, that asks, at some point you need to, again, when you know those limitations, you might want to refer somebody, and you know that you're not the best person for the job. You might wonder if you should refer that individual to another doctor. And so,
I have an example. So if you're in practice, and this kind of too depends on the urgency of the situation. So if the situation is a very acute situation and the risks are very real that this patient could suffer serious illness or injury or even death, that's a little bit different. So if you're in a situation that is very acute, then you need to refer acutely. If you have a patient and you've determined, because you are well educated and you understand that you have some time, you can take some time to try to better yourself for your patient, but you always have to realize that it's the patient's call. So your job is to present your patient with all alternatives in a very open way, and understand that at the end of the day, it's the patient's decision. Now, you have to lead them sometimes and help them to understand, but at the end of the day, it is the patient's decision, and so you have to put your ego to the side. So it kind of depends on how acute the condition is and what the risks are.
That's a great question. Thank you. So another great question is, when is the time to push your limits versus knowing them?
If it's going to negatively impact the patient, then you shouldn't be pushing your limits. So pushing your limits, to me, is kind of more of an egocentric type of thing, like I want to be the best, and that's fine to push your limits. Push your limits in education, push your limits in availing yourself of information and becoming a better practitioner, but you shouldn't be pushing your limits and testing yourself above the welfare of your patient.
So we're still here. We're both just reading some of the questions. So The question is, with the book it appears that new arenas in medicine like mind-body medicine will hopefully have a better receptivity. How do we attempt to measure some of the non-linear aspects of the field?
That's a really good question, and it speaks to the fact that not everything, we're not able to quantify everything. And so absolutely, mind-body medicine is becoming something that the public is becoming more aware of and physicians are becoming more aware of. And it definitely speaks to that fact that there are some things that we just cannot quantify. And, you know, as physicians, we need to understand our limitations, and then we need to find new ways to try to understand things that are not quantifiable.
Great point. Wonderful. Well, I just want to take the opportunity to thank Dr. Howell for this wonderful presentation. We have recorded it, and we will post it on our website if you wanted to refer back to it. I think you are all in for a treat once you have Dr. Howell in one of the classes, whether it either be in the first year or the second year. She truly knows her stuff, and I know will challenge you in many great ways that will make you a better practitioner. So if there aren't any other questions, I want to thank you all again so much for taking the time to read the book and to participate in today's presentation. As I mentioned earlier, we look forward to having you on campus in just a very short amount of time. I know that you are busy wrapping up final prerequisites and are moving into our community. And of course, if you have questions about any of that, anyone on the admissions team is here to help you with that. So thanks again so much for your time. And with that, we will conclude. Hold on, we're looking at more questions.
There's another question.
So somebody's,
I would really like to address that. So somebody said that the conventional medicine is more like hedgehogs and alternative medicine will be the foxes. I just want to dispel that idea. Once you start to know people, you can't really categorize entire professions in that way. There are plenty of hedgehogs in naturopathic medicine, and there are plenty of foxes in allopathic medicine. So I just have to say that's a very simplistic idea that you could, you know, categorize an entire profession that way. Also, alternative medicine does not just use observation rather than theoretical approaches and science. So I want to kind of dispel that. There's really not a difference between naturopathic diagnosis and allopathic diagnosis. You have to know what's going on with someone before you can determine the treatment protocol, whether it's naturopathic or allopathic. So I want to make sure that's understood too. And I really want to say that thank you for being here today, and I can't wait to get to meet all of you.
Awesome. Thank you again, Dr. Howell, and thank you again to all of you. As I mentioned, please let us know what we can do to make your transition to our either to the SCNM community or the Tempe community easier. We look forward to having you on campus very soon. And with that, the webinar will conclude the webinar. Thanks again, everybody. Have a great afternoon. Bye-bye.